पूछो जाके उनसे जिन पे रोशनी नहीं, पूछो जाके उनसे कैसी लगती है कमी.
So hello everyone, Nigat Shadab this side. I welcome you all to the Optohub, a platform of interaction, learning, glowing and growing. In today's session, we guys will get to know about management of amblyopia by Mohammad OLIULLAH Abdul Sir. He is the founder, director of Binox Vision Therapy Software. He has obtained his optometric degree from George College of Management and Science, followed by research training at LVPEI Chitkara University. He is well versed in binocular vision, vision therapy, and visual optics, and much more. Thank you so much, sir, for accepting our invitation for today's session. And I know it's going to be amazing, so we are keen to hear you. Over to you now. Please continue.
Thank you for the warm welcome, and it's a great initiative from Optohub to carry out educational programs like this. And thank you for having me here. So today I'm going to share my experience on amblyopia management, and the session is intended to let you know what are the amblyogenic factors, like why amblyopia happens, what is the major issue in the visual system, and what are the expected outcomes in the management. So our real life expectation, which group of patient is going to improve, and what kind of patient is going to improve in which mode of treatment. So during this presentation, if you have any queries, keep putting in the chat box. We'll be taking the answers or questions and answer one by one. And if you wish to talk directly, raise your hand after the presentation. We'll unmute you and then you can go ahead with your question. So to start with, as a small definition of amblyopia, as we all know, it is unilateral or less commonly bilateral reduction in the best corrected visual acuity that can not be attributed directly to any effect of the structural anomaly. As in, when I'm talking about structural anomaly, means eye structures, anatomy is normal, the function, physiological functions of the eyes inferior, and you have lesser visual acuity. Now, when we talk about the visual acuity, we always look for the functional acuity or the resolution acuity, how much patient is reading on the visual acuity chart. So if you see a patient, you look at whether it is 6.6, 6.9, 6.12, and so on. Please remember, amblyopia is not about just the resolution acuity. It is beyond that. So what all things you need to look at? You need to look at their near visual acuity, their binocular vision functions, very importantly, whether they having binocular vision or not, whether they having fusion, stereopsis or not. So these are the parameters we need to look at in amblyopia. There are certain higher functions also needs to be recorded if possible, like patients' saccadic eye movement, pursuit eye movement, eye-to-hand coordination scales, perceptual scales, but those are done usually at tertiary vision training centers or in optometry practice where vision therapy is exclusively done. Having said that, as per the definition, we look at only the resolution acuity, which is in form of like 6.6, 6.12, or whichever the notation we use. Moving forward, as we know, the prevalence of this condition is quite high. 2 to 4% of our populations are actually affected. And most of the time, all this population, nowadays, what you get, when they go for any kind of medical examination for job or any kind of courses where they need that physical fitness, they come across, oh my God, I have amblyopia. I'm not able to see from one eye because all the point of time, one eye is being used and having a better visual acuity in that eye. So lately, this patient come to know that they having issues. So if you look at that complete population or the kind of population which are affected, which is almost 4%. Different literature says different amount, but in India, it is different part of India projected at 2 to 4% of the population affected. and as commonly it is most of the time in one eye, and nowadays you also, because you are picking up the things very nicely and you know what to look for this condition from this patient, and you also get meridional amblyopia, isometric amblyopia, quite few in our OPD patient, right? Now the best part of this population which is getting affected, actually you can reverse this visual loss that is happening in this group of patients. So there is a condition which is quite common, and you have option to intervene and reverse it. If it is children, then you can reverse this faster. If it is you can do the amblyopia management, and if you can identify this condition at the earlier age group, then the prognosis is going to be the best. So the outcome, not only in visual acuity, in terms of fusion, stereopsis, everything becomes good when you identify them at the right stage.
What about the patient that we see in amblyopic population? Based off the part, it is reversible, and if it is detected early age, then you can reverse it. Earlier the age you detect, better the prognosis, and why so we'll discuss going forward. Now, to understand, I know you people are already aware of many things, but let me just go through a quick poll and understand. We come to the first poll to understand your perspective on what is the commonest type of amblyopia you see in your clinical practice. So on your screen, you will have 4 options. As per the thing, you can choose the right one. Please feel free and answer the question on your screen.
Okay.
That's great. So as I can see, many people are responding already. So what is the commonest type of amblyopia you see in your clinic? And I can see also people who says that yet to start their practice, and super. So this makes me good, feel good that the population I'm talking to. So as you can see, most of you felt, which is 36% of you felt, that anisometropic amblyopes are more common, followed by strabismic, and 27% are students probably that they're yet to start the practice or internship. And you are bang on, absolutely correct. So most commonly you see anisometropic amblyopes, and then you see the other different type of issues or different type of amblyopia. Now, the interesting fact that we need to understand in amblyopia, that where the problem lies, what is the actual neurophysiology of amblyopia. So if this point is clear, it will make the management part very simple. So let us focus a little more time to understand what is the actual neurophysiology of amblyopia. So whether it is in the level of eye or in the optic nerve, lateral geniculate body, or visual cortex. So probably if there was a quiz competition or for the participants, I would have rather love it. So here comes for the poll number 2 to understand what do you feel there is an issue in which part of the visual system is responsible for amblyopia. So in amblyopia, which of the following is affected? You can choose multiple, you can choose one. So let me see what you guys think about. Amazing. So 100% feels visual cortex. Oh, there you go, coming different responses. Can I have a few more? Interesting. So are responding to this large population who is saying visual cortex. Super. Feels good. So as you can see the results, 86% of you feel that it is in the visual cortex, followed by 21% in the optic nerve, and tie between the eye and lateral geniculate body. Now for everyone to understand, those who feel, 86% who feel visual cortex, those also feel in the eye level. So let us understand what actually happens in amblyopia. So if you see this component of the visual pathway, these are the visual pathways we need to look at. So there are photoreceptors in the retina. There are bipolar cells, ganglion cells, again in the neurosensory retina. And these are nothing but called first, second, and third order neurons. First order neurons, photoreceptor, bipolar cells, second order, and ganglion cells, third order neurons. So it connects from the stimulus converted into electric impulses and carries forward to the optic nerve. Now in amblyopia, these first, second, and third order neurons are absolutely normal. So to understand that there are no issues into the eye level. So first order, second order, third order neurons are normal in amblyopia. So what happens? Where is the problem then? So if you see that problem actually starts from the fourth order neurons, which starts in the lateral geniculate body, which is also known as thalamus. Okay. And next in the visual cortex in the Brodmann area 17, which is fifth order neurons, and followed by extraocular cortex, superior cochlear. And these are the fibers on the pathway, neural pathway, which are affected in amblyopia. Now, to understand why I'm putting more and more stress on this, so this is monocular, as in the eye, if something is affected, photoreceptor, bipolar cells, and ganglion cells, it is in the same eye. But the moment it starts from lateral geniculate body, you know there is a binocular environment. Both the eyes neurons are getting intersected and having component into it. So this is binocular, visual cortex is binocular, and extraocular cortex is also binocular. So the pathophysiology of amblyopia is a binocular phenomenon. To understand what we feel that it is mostly a one eye problem, so we need to discard that thought process and let us rewrite that concept of amblyogenic factors, that it is a binocular phenomenon. Okay, so what actually happens in the lateral geniculate body is, if there is a stimulus deprivation in the earlier childhood or in the maze, actually it was tried. So the cells, it becomes pale, and you know when the neurosensory cells are pale, that means the functionality is much inferior than the normal one. Ideally, it should be a healthy one. So it becomes pale and shrunken, it becomes constricted, smaller in nature. So when it becomes smaller, then a lot of crowding effect happens into it when there are visual stimulus. Then it occurs if only there is early deprivation, and if you remove the deprivation, it is not going to improve on its own. So that is the issue. So if there is a deprivation, suppose there is a form deprivation, stimulus deprivation, whatever deprivation of the proper image is happening, and then there is an amblyogenic factor which is happening, that's why the lateral geniculate body cells becomes pale and shrunken and amblyopia is happening. So if you just remove that, that means if you just correct with the spectacle, or if you remove a cataract which was there, or ptosis which was there, it is not going to improve until and unless you cover the good eye. So patching works when there is early deprivation and the right age you covered. So component of the lateral geniculate body which is affected for this is going to be helpful. So closing of the good eye in critical period had recovery. So critical period for the monocular neurons. So till 7 years, 8 years, or 10 years of age. So if you cover that, you get improvement. So traditional mode of improvement works based on this principle, that if there is early deprivation and you remove that deprivation, cover the good eye, there is going to be improvement for this patient. Okay, so that's why the patching therapy works in early age group. Okay, and there is no permanent atrophy which is happening. But what happens to the other component, which is for visual cortex? Let's see. So if you see in this component in Brodmann area 17, 4C, more precise, so whatever the inputs comes from the lateral geniculate body to the visual cortex, it becomes shrinkage. So it is so confounding, crowding kind of cramped images are falling in a small area of the brain in the visual cortex, and that leads to dominancy from the other part of the visual cortex. So if right eye is amblyopic or having a poor inferior visual stimulus, so a lot of cramping happening in the right eye, and the left eye visual cortex area, what is happening? It has dominancy, expansion of that area. So exactly it's explaining. So expansion of the non-deprived eye. So better eye will get expansion in the visual cortex. And whenever there is an expansion, it is going to dominate over the non-expanded eye. And that's why the quality related of amblyopia stays here. So there is a binocular competition between two eyes. A dominance is taking place, and the depth is depend on this kind of expansion. Larger the expansion of the dominant eye or better eye, larger is going to be, or denser is going to be your amblyopia. Okay, so this was a concept or pathophysiology or neurophysiology of amblyopia. Now coming to the next point, or to understand before I go to the next segment at all. So let me understand the third polling question. So after this, once you understood the pathophysiology or the neurophysiology of amblyopia, so what going to be your best management plan? Suppose there is a kid, 7 years old child, came to your clinic. Even for the students who are not practicing it, you know the pathophysiology now, that if lateral geniculate body is affected, then during the plasticity period you can just occlude and give the therapy. And if you want a better outcome, so it is just taking care of only that portion, but what happens to the binocular component? So by saying this, so what could be your preferred management plan? So if you have a child, or 7 years old child with anisometropic amblyopia, then what is going to be your preferred mode of management? So as I can see that people are preferring occlusion therapy, and then somebody feel penalization, and then there are only 3 options, so you can choose any of these 3, and then some of you are thinking vision therapy. So each and every one who is responding is right in their way. Today's session is going to, again, will explain each and every component and understand what is going to be your ideal. Okay, so I'm then ending this poll, and interesting facts that has come up. So as you can see, 53% you failed occlusion therapy is the ideal for you, and then followed by 13% penalization. Penalization again is a form of occlusion therapy in a different mode. So it is constituting almost like 66% of the voted people, and only 33% you fail that there is a component of vision therapy which is going to help this. So this is the result now. We'll see end of the lecture what is going to be your preferred mode of treatment after understanding each and every component what is being projected here. Great. So let us go through the next section. So there are a lot of people talking about, okay, patching therapy is there since like age old, which is years and years or 100 years of the time. Then why do you need a different approach? Why people are talking about you try this, you try vision therapy, you do some kind of movie watching, some kind of 3D movie watching, or you just use the shutter goggles. Why people are thinking about it then? There is something which is missing in the standard, gold standard, which is, as you know, that patching therapy is the gold standard which is there at this point of time. But there is something wrong into it or some limitation into it. That's why you are trying to look at a different component. So there, the next question comes, what are the limitations that we have in patching therapy? Let me see how many are correct. So how many of you already know the major limitation of this patching therapy. So next question for you. What are the major limitation of occlusion therapy? You can have multiple options to choose before you submit. So as 53% of you noted that occlusion therapy is going to be your major or the preferred mode of treatment, but we need to understand what is the potential limitation of this occlusion therapy. So mix and match. So poor binocular vision development is leading in the race, followed by we can see residual amblyopia has come up quite few now. Excellent, few more. So let us take more time. Good. So people feel that poor binocular vision and does not work in older age group, residual amblyopia. Super. So ending the result and showing you how it looks like. 64%, in fact, you feel that poor binocular vision development is an issue in patching therapy or occlusion therapy. And then 45% you feel that does not work in older age group. Again, very true. And then 36% each in residual amblyopia, poor compliance. Poor compliance could have been one of the topmost, because if it is older kid, nobody wants to wish to patch. If you give for 3 hours, they will only patch probably a couple of hours, and that's it. So we'll go by it as you are right. Most of the components you felt absolutely right. So residual amblyopia, this is the amblyopia treatment study group called ATS from Pediatric Eye Disease Investigator Group, or PEDI from US. They noted that if you give patching therapy, so what happens that 85% of the patient whom you treat will have at least 2 lines or more residual amblyopia. So 4 months of patching therapy will still remain with at least 2 lines of residual amblyopia. Now, if you do it for years and years, then probably this becomes better and better. Okay, so I'm talking about that at the level of 4 months of time. And some component lies with the form of either near vision, binocular vision, or some component it is there. Followed by the compliance. Compliance is the second worst condition that to happen in amblyopia. So if the age group you are treating is more than 5 years, then less than 50% is going to adhere to your treatment protocol. So younger the child, they will still patch because you are forcing them. But if it is more than 5 years of child, if you ask them to patch the eye, they are not going to patch it. So that is a second major demerit of patching therapy. And third is a slow improvement. So you need months and months of patching therapy to come out from the separation. Followed by, there are many like adult amblyopia, there is no efficacy. Then recurrence, if you stop the patching, again 1 or 2 lines vision drops down. So 8 to 10% of patient usually drops down with patching therapy. And this deficits in their binocularity like fusion, stereopsis, eye to hand coordination, ocular motor deficit like circuit pursuit, these are actually unmeasured demerits for amblyopia management. So this is the reason where you need to look at to make it better compliant, to make it better adherent to the protocol, effective in other age group, and have improvement in their binocular visions, led to a different mode or different kind of approach to treat amblyopia. So that led to a vision therapy concept. So vision therapy is not just training something vision, it is working on the neurosensory component in the brain. So as you can see, to invent into a vision therapy, what is happening, you are including both the eyes into context. So you are trying to go in way of binocular vision, or the second component what we talked about, and you are forcing the eye, the monocular neurons, to help in improve their visual acuity. So what is happening in this, something the first and foremost come into our mind is something, a phenomenon called monocular fixation. in a binocular field. So in monocular fixation, the term itself is saying that you are focusing from one of the eye, but the environment where you are focusing, it is binocular. So given a very simple example, suppose you have this color cards, playing cards. So you have white background one, and what you did is simply you put it a red gelatin paper onto another side. So there is one without the gelatin paper, or a red filter card. You can get plastic one, acrylic one, or you can get a gelatin paper and just cover it. The moment you do that, so you can create this kind of environment, or else what you can do is you have this angular goggles. See, this is very commonly available in Amazon. So instead of red and green, you have red and blue, which is commonly available. The moment you put this on, then the red filter, so red one becomes, so the moment you do, one side become blank, the other side become visible. So the layout of the card is same, but it becomes very specific to one of the eye. So if I need to see the card, playing card, I need to use my one of the eye precisely. So if it was red and green, so as you can see, the moment you cover the green, or which is in this case the left eye, the patient sees like this. If you cover the right eye, it is visible this card. With both the eyes open, actually patient is seeing both the cards to see. So one you covered and one is uncovered. But only a simple thing you need, a pair of angular goggles to start with this component. Very interesting concept, very useful. It is a binocular field which is getting used, and you are going to get into a newer approach of amblyopia management. I'm not going into older one like what patching therapy, what the treatment schedule, because that is there in books, and a lot of all of you must have aware of the protocol. So I'm going to only the newer approach of managing it. So with this, I'm ending today's session and open for discussion and question answer.
Thank you so much, sir. It was a very nice session by you. It was very informative and you explained everything very well. We got to know a lot about amblyopia.
So guys, thank you so much for watching this video. I hope you like it. So please don't forget to give it a big fat thumbs up. And to know more about it, you will have to watch the part 2. So which will be uploaded soon. Thank you so much once again. Please write the comments in the comment section how you like the video. Thank you so much.